So it's basically working as a team. And if we're going to prevent errors, everyone is not infallible. We try and pride ourselves on 100% accuracy as pharmacists. It doesn't always happen. Even with the scanners, if you input the wrong data, it will scan the wrong data. So you might get if you misread a prescription of the few handwritten ones we get now, and you read the wrong strength as 0.25 milligram digoxin, and you type up the label as 0.25, you select it from the shelf, you scan it, it goes out as though it's correct. But the error was right at root cause of the misreading. So it doesn't actually cover everything by using the electronic scanners. So it's not just one person, it's everything. And I'll show you where the pharmaceutical companies are, I think, causing more problems with warfarin. And we have a look at that in a moment. TGA are certainly helping to alert us with things. So it's basically working together for safe prescribing, checking what's going on, and are the people taking their medicines and how are they taking them? And that is horrific. I've done about 10,000 visits to homes with people doing home medicine reviews, and I could tell you that it's not what you think it is, and it's not what the doctors prescribe that they're actually taking. And there's absolutely little correlation between the medical history that you have from whatever source that there is in the GP surgery, that is in the hospital, and what the person's taking. They are different entities. They decide what they're going to take, how they're going to take it, and when. Yesterday's one, she was cutting her esomeprazole in half. And as you know, that one is destroyed by the gastric acid. She was wondering why it wasn't working as well, but she doesn't want to change. Difficult. So it's collaboration, working together. And for many years, I worked for the 2 divisions of general practice, and we ran once a month events for GPs, pharmacists, nurses, and any other allied health. Highly successful, 70 people jammed into a small room, putting on a pretty basic meal first, and I had companies coming to me wanting to sponsor. What we did case studies, we talked together. We don't do enough of collaborative training, and that's what we've got to start to think to do again. Sitting down and getting other people's viewpoints. We've also got to speak the same language. We've got to use the abbreviations that people know and using evidence-based medicine, Australian references, Australian guidelines where possible. So your CPD needs to be accredited, up to date, meaningful, making a difference, and you need to enjoy it. I mean, I love going to conferences. People have said, I've seen your lovely slides. You had a wonderful time this year. Yes, we went to Greece. We have a great time. We do education in the morning. We go traveling around in the afternoon and do things. I've done that the last 10 or 12 years. So, okay, it's enjoyable, but we take our education in small bites, and that works really well. I can't help but put this slide up of essential resources. Australian Medicine's Handbook, the latest edition. I've just paid for mine coming up for next year, the continuing of the online subscription, which comes on your phone as well. But also I like the hard copy because sometimes I just want to look and read it while something's up on the screen, and I don't necessarily always want 2 screens going. The AMH Drug Choice Companion, Aged Care, is invaluable, and there'll be a new edition of that one coming out in hard copy and online. It's about $100. That's one of the cheapest texts out. The AMH lists the drugs by the actual drug. The AMH Aged Care lists them by conditions. So if you want to find what you do for congestive cardiac failure, you can look up that, or COPD, and it will give you 2 pages reference to the Australian guidelines of what needs to be done. How easy is that? It's just people who haven't got it are making life harder for themselves. Well and truly worth it. MIMS, whether it be the cloud or the eMIMS, or whether it be OSTI, are basically collations of the product information put together by the companies for the purpose of registration of the drug by TGA in Canberra. So that is only updated when the sponsor company takes their new submission to Canberra. So OSTI differs slightly in that there's 2 parts to that one. It's got the product monographs, but it's also got independent monographs that can be updated today or tomorrow if something happens. But they are generally available on most of either MIMS or OSTI are available on most of your computer systems if you're in the teaching hospitals or in larger organisations. The individual practitioner has more trouble getting them. Therapeutic guidelines are centred in Melbourne, invaluable, and they only get updated on a cyclical basis. So you need to be aware of when they were updated, is it the latest or not? But generally they are updating them online a bit more. If you want a disease state text, I actually have to promote the text by John Murter, who was the Professor of Community Practice at Monash University in Melbourne here. Pharmacology text, if you must. They get out of date pretty rapidly. I teach pharmacology to the nurse practitioners, but it's really clinical pharmacy. And then you can use a dictionary. I don't care if you use a dictionary online or Google it. And the other invaluable one is the Society of Hospital Pharmacists Don't Rush to Crush. I should have brought it along, but it's that thick and it's a big book. And I've been involved in the last 4 editions. The 5th edition I'm going to be involved in starting next year. It's online. It's a part of the OSTI and it's also part of EMIMS. It lists the about 600 odd monographs now of medications that are at danger when they're crushed or they're taken out of their capsules. Goes through the oral administration, but it also goes through the nasogastric feeding. So invaluable for you, and is available in mandatory in every hospital in Australia, and every pharmacy is supposed to have the most up-to-date edition of it. So you don't need to have it, you should be able to get it, but be aware that it's there. People say to me, I just want a double-sided A4 piece of paper with the medicines that can't be crushed. No, those times have gone. So you've got all these XR, CD, CR type forms that if you give them, if you crush them, and we've had deaths from that happening. The worst one was isoptin, 240 milligram, slow release. A PCA crushed it. Instead of going over 24 hours, you get the whole lot all at once. The myocardium says, hey, I think I'll go really slow. I think I'll go so slow and I think I might stop. So, and the poor little PCA had no idea. So it's education about reducing risk, a major one. And as people are getting older, we've got people after strokes, we've got so many cases of dysphagia. So latest edition, the RACGP website offers a silver book for those working in aged care. It offers stacks of information on that website. So do have a look at it. A lot of it is free as well. I'm actually on the writing committee of that as well. We've just added now part C, and we've added more of preventive care in diabetes and osteoarthritis. And the RACGP Diabetes Handbook is being updated as we speak, because what's there currently is out of date, as Michelle will be saying with that one. And then Clinicians Health Channel, if you're lucky enough to have that, and you might have that through the university or through the hospital, you can get all this information for nothing. Yes, okay. So essential resources are part of your CPD training. Your TGA alerts with the upside down black triangle. You've got your online journals, of which significant articles are often freely accessed with it. Have a look at your disease state websites. They get updated pretty rapidly. The Heart Foundation has got a new cardiovascular risk calculator. If you haven't checked your risk lately, have a look at it, use it and download it as well. The National Asthma Council has got its website. I'm actually involved in that one and we're just about to update that one as well. The Stroke Foundation, Lung Foundation, Diabetes Australia, Osteoporosis, all of them have got fantastic websites with patient resources and health professional resources. I don't think we utilise them sufficiently. There's been a new edition of Ausmed of Fitness to Drive. If you haven't had a look at that, vital. Comes in 2 parts and it tells you how long is it before somebody's had a stroke, how long if they've had bypass, how long if they've had a pacemaker before they are seen as hopefully safe to drive. A major concern with that one. And can they drive if they've got dementia? The answer is, it depends. There are people driving who have been diagnosed with dementia that are considered safe. One could argue about that or not. I do have people in the aged care homes where I work that are still driving. 86, I had one man the other day, and his GP had decided to stop a massive dose of Palexia, about 135 morphine equivalents, down to about 30 morphine equivalents of moving you over to oxycodone naloxone. And he was out on the road driving to a gastroenterologist appointment when I found this. So we actually got it rectified by the afternoon. And the GP said, I actually didn't think of that was quite as potent as what it was. And that guy would have had huge withdrawal symptoms, a hazard to you and I on the roads. So passionate about drugs and driving. I've done a lot of work on that, and we mustn't overlook it. A hard one. We've now got the Safety and Quality Council replacing the clinical sheets that the NPS used to do. They are good, but people don't know they're there. So have a look and see those clinical sheets. They're coming along rapidly. We have deprescribing guidelines, invaluable. We've got lots and lots of different sources of deprescribing. The most user-friendly one I find is the one developed by the Tasmanian Primary Health Networks. You just Google deprescribing Tasmania, PHN, it'll come up. And you've got 21 sheets there of general principles of deprescribing, 4 or 5 pages about each particular disease state, so you can get up to speed on your disease states as well as deprescribe. We're using too many medicines. Often people are staying on them too long. So that's invaluable. Then you've got your pharmacists sitting on the hospitals. You've got them sitting at the industry, at the pharmaceutical companies as well. You've got primary health networks doing training. We've got CPD online webinars, Health Ed, Diabetes Australia, Inside Practice, Ausmed, and so much Ausmed that's just incredible what's there. And not just because Zoe's there. It's fantastic. I can't believe how much you've got. But you've got face-to-face versus online. So something to suit you when it works. It's a matter of keeping up to date with it.